Hi there, everybody. Good evening, Unite for Her community. Sue Weldon here. I'm the president and CEO of Unite for Her, and we are so excited to have our Ask the Experts this evening with a very special guest, Dr. Monique Gary. As many of you know, the new guidelines came out, and we've had a lot of questions that have come our way, and we felt like it was very important for us to actually have this segment once again to clear up a lot of these questions on the recommendations that were released in April. So before we dive into that, Ask the Experts for today on all the screening guidelines, I just want to welcome you and make sure that you know that we are live and we are going to be watching the chat. So please give me your questions. We've already gotten quite a few questions that have come in already. So know that we will be answering as many as we can in the next 30 minutes. And also know that we have another Ask the Experts on May the 30th. It's at 1 o'clock. It's with Dr. Tashina Reeder, and she will be joining Erin, answering all your questions about processing trauma and strategies for overcoming emotional and psychological roadblocks, addressing trauma related to disease reoccurrence, and much more. So know you can submit your questions. We'll put it in the chat at uniteforher.org/experts. All of our past Ask the Experts are all in our library. There is a wealth of knowledge. Erin and I just actually went through there, did an inventory, making sure that everything was up to date, and it is impressive. So please get there at uniteforher.org/library, her library, and you can learn more about a host of topics that you might be interested in. All right, so today's topic, as we talked about, is discussing the latest mammogram recommendations. And it's all from the U.S. Preventative Services Task Force. It's an independent volunteer panel, national experts that make these recommendations, focusing on disease prevention. And the recommendations state that women who are average risk for breast cancer should start their mammography screening at age 40 and get one every 2 years, up until the age of 74. Previously, that task force said that women should start mammograms at age 50. And this new advice does not apply to women considered high risk, including those that have had breast cancer or carry the genetic mutation that increase cancer risk, or even have had a high risk breast lesions on previous biopsies. So we wanted to go through all of the different areas just to break down some of the questions and put that recommendation source link right in the chat for you. And there's no one better than we know, always my first phone call, than Dr. Monique Gary. So Dr. Mo, we are so honored to have you here tonight. I wanted to do a quick bio just to share a little bit more about you, Dr. Mo, and share all that you've been able to do with the Unite for Her community. Dr. Mo is a breast surgeon, educator, entrepreneur, media personality, farmer, and philanthropist. She currently serves on the medical director as the medical director of the Grandview Health Penn Cancer Network Cancer Program, where she also serves as the director of the breast program. So Dr. Mo, thank you for coming out again. We did one of these screenings already this year, but now we have all of these follow-up questions. So really grateful for your knowledge and your expertise here, because there's a lot to digest, right?
There is, and it's still sort of confusing. It's about as clear as mud. So thanks for having me. I hope I can answer some questions and provide some clarity where I can. And I'll provide the disclaimer that this conversation is not intended to diagnose or treat anyone, and you should talk to your doctor about it. We're gonna give you some tools and some questions to ask, but hopefully shed some light on what's going on and how can we empower women to take control of their breast health.
Perfect. Love it. All right. I'm going to dive in because there are quite a few questions that have already come in. So one of them was, why aren't MRIs the standard instead of mammograms? Mammograms sometimes miss certain things, especially for women with dense breast.
It's true. And what people should understand is that there's different techniques that are all used to analyze a breast. So mammography is considered the gold standard. It basically utilizes x-rays. And x-rays look at the thickest, densest, whitest thing. So think about an x-ray of a leg. You see the bone, you don't see the muscle, you don't see the skin, right? And so mammograms look at the thickest thing, which is the dense breast tissue. So it's sort of like looking at a cloudy sky, and then you're looking for a cloud within that cloudy sky. Ultrasound uses sound waves. It's like looking underwater, think looking at babies and sonograms, but it looks at basically the sound waves so that things that are fluid, things that are masses are going to reflect that sound. Like if you stick your fist in front of a megaphone, if there's a mass, the sound will go around it, but not through it, and it gives a shadow. And that's how we know if something's suspicious. But it doesn't necessarily pick up the densest little things like calcifications or the granules, salt and pepper granules that mammograms do. So every study has limitations. MRIs use magnetic waves. And so there's no radiation, so people should be aware of that. It does for breast utilize a dye called gadolinium, and it basically analyzes the blood flow in and through the breast. And then it looks for areas in the breast that are picking up or holding on to the blood supply longer, because those things might be growing, they might be changing. They might also be inflamed. They might also be post-biopsy. They might also be fibrocystic changes. And so the reason why MRIs are not recommended as a primary screening tool is because it's very, very sensitive. Lots of things light up on an MRI. It's like looking at the night sky, looking at a starry sky. You see lots of twinkles. But then what's a planet and what's a star? And a planet meaning a tumor or a mass or something important. And so while they're very sensitive, they're not very specific, meaning women after MRI need more imaging. But almost 40% of women, I tell my patients, don't be alarmed if they call you back after this MRI and say, we need to take a second look. We need to pull out our telescope or our ultrasound and see what's in this area, because things are lighting up in your breast and we don't know what that means. And so because the MRI is very sensitive, it can lead to a lot of false positives of things that women then have to spend money and spend anxiety and time and go back for additional imaging. And so it's the reason why it's recommended when we know there's high risk, or when we know there's a cancer and we're looking to make sure there's no other cancers around. But as a general screening tool, it's expensive, it's time consuming, you're in a tube face down, and that gadolinium is not without consequence either, the dye.
Yeah. Oh, thank you for that. That was a great explanation. I feel like, as somebody who, went through breast cancer, and I think of the MRI is something that I always thought like that was a better way because it was more detailed, but you don't realize how many false positives are going to come from that, right?
Every movie shouldn't be in 3D IMAX. Think about it that way.
Ah, good. Awesome. All right. So what is your recommended protocol for someone who's had a double mastectomy? Next question up.
Ooh, so double mastectomy means we have removed as much of the breast tissue as we can. So I'm a breast surgeon, and so that's what I do. It's kind of and the way I explain it to patients is like this, because the question is, well, how much breast tissue gets left behind? And folks don't understand that after a mastectomy, the risk of breast cancer is not zero.
Yeah.
We remove as much as we can, but the reason it's not zero is because underneath the skin's a thin layer of fat, more in some individuals. Underneath the fat's the breast tissue, and separating those layers is like shelling out an avocado. I told you I use a lot of food analogies, but if you take your spoon and you shell out the avocado, right, and you look inside that shell, what do you see?
Yep.
A little bit of green, right? Just like when we do a mastectomy, under that skin, there's always a little thin layer of some breast cells that are left. And so the risk of breast cancer for the rest of your life, less than 2 to 4%. It's 4% in the old studies from the 80s and 90s where they leave this much skin and breast tissue and you had really thick, we call them thick flaps, right?
Yeah.
Now they're kind of like this. I know you can't see because of the background there, but they're kind of thin like that.
Yeah.
So 5 millimeters, think about pencil eraser, half a pencil eraser thick. So there's no more breast tissue really, which means there's no more mammograms. Because what are we compressing?
Right.
And so the NCCN, the National Comprehensive Cancer Network, is the Bible that all cancer doctors follow. They don't recommend any more imaging after a double mastectomy, not in the breast. Now, if you have symptoms or if you have advanced disease, your oncologist may order PET scans. A plastic surgeon may order an MRI to look at the implants and look for rupture, but not necessarily looking for cancer. So there's no recommended imaging for the breasts after a mastectomy.
Okay. Terrific. Thank you.
Mm.
We have one woman that said that she completed her treatment for triple positive breast cancer, Dr. Mel, and now she now receives annual mammograms. The mammograms I receive require an injection, which I was told by my breast surgeon produces imaging with more contrast and therefore a clearer image. I have 3 questions related to this. I have never heard of this type of mammogram prior to having breast cancer. Is this a new type of imaging?
Yes, yes, it is.
Why don't I also have an ultrasound?
Uh, Good question, and it might be related to breast density. If we can see what's going on in your mammogram, and we're now adding a contrast, so an iodine-based contrast. So CT enhanced mammography or contrast enhanced mammography uses IV dye in combination with your mammo. So now we can see the vessels, right? We can see a little bit better what's going on in there. Now that iodine dye, some people have allergies to it and everything, and it can affect the kidneys, but it is a newer technology, FDA approved, so that we can now look inside the breast. So if we can see everything, you might not need that ultrasound. But if you have heterogeneously dense or greater breast, meaning 50% density or more, you might be a candidate for an ultrasound as well. And that's something to ask your doctor about.
Great. And then her third question is, why is the imaging done only once a year instead of every 6 months if there's a chance of recurrence? Without an explanation of this type of mammogram, I'm concerned that I am not receiving sufficient imaging.
So there are very few recommendations for twice a year mammography. Most mammograms are annual, and then we will alternate with some other technology like ultrasound or MRI. So it's not unusual to find that you've been ordered a contrast enhanced mammogram for once a year. That's pretty standard. The Preventive Task Force guidelines, actually, to that point, the guidelines, USPSTF recommend every other year.
Right.
And this goes against all the doctors who practice oncology, breast cancer especially. We all recommend, the clinical recommendation is every year screening. It's
Yeah.
not twice a year. We're aiming for once a year even. So this person's asking about, why can't I get twice a year? We're just trying to get the task force to give us annual in the guidelines and recommendations. And they're saying that the benefit of annual mammography doesn't necessarily outweigh the risk. And so there's a whole conversation we could have about, well, what are the risks of mammography?
Yeah.
That,
Yeah.
might be a little bit beyond the scope of this conversation. But the reason why is because they are thinking about the false positives. We see dense tissue, now you need an ultrasound, right? We see a nodule, now you need a biopsy. And because the imaging's so good, we're picking up all these things that weren't really clinically significant. And so they're making women have false positives and lots of fear. And so they're saying that because the mortality isn't increased, we should do a little bit less screening because we're over screening everybody. That's what the Preventive Task Force is saying. We don't agree in the cancer world. So
Yeah.
let's just make that clear that all the oncologists and anybody who does breast cancer work, we all recommend every year. But to this person, we don't recommend twice a year mammograms anyway. You're getting a contrast enhanced, which is the newest, most latest thing. And so you might talk to your doctor about why you couldn't get an MRI or an ultrasound in between. But if your cancer was very visible on a mammogram, you don't necessarily need those other imaging. And so this is important for people who got an MRI and then they found something and now your surgery changed, right? You had a little something, they did that MRI, and now we see you have more going on, or your cancer didn't show up on a mammogram. You should get additional imaging because your cancer never showed on that screening mammogram.
Yeah.
Sorry, that was a lot.
The American Society of Breast Surgeons, I mean, you're recommending every year. So why is the task force not taking into effect what
Yeah.
you recommend, Dr. Mo?
Well, and it's really interesting because when you look at the levels of evidence, right? Because it's like, well, how strong is this recommendation? Because the task force will recommend something and then they'll say how strongly they recommend it. So grade A recommendation means they highly recommend it. There's a high certainty that the benefit is substantial. Grade B means there's a high enough benefit, but moderate certainty. The recommendation for every other year mammography is grade B. It's not even a grade A. So
Mm.
even they're saying, we recommend it, but it's not that high of a recommendation. And so it's not clear to me why they recommend it, other than the fact that what they're saying is that because women are living longer and getting more and more treatment for a disease that they might not die from, we might be over treating. They call it overdiagnosis. I don't like that term overdiagnosis. It's like you're pregnant. You either are or you aren't.
Yeah.
But I don't know a woman alive who wouldn't want to know she had a breast cancer, even if she wasn't going to die from it. And I don't know a woman who wouldn't want to be treated for it, even if she weren't going to die from it. Because how can we know whose cancers will and won't spread? And so there's a whole conversation about molecular testing and really knowing more about cancer to understand whose cancers may never go anywhere. And maybe those are people who can avoid some of the surgeries or radiation or other things. And we're learning that. But to me, because women aren't dying from it and they're living longer and they have higher survival, doesn't mean we should do less screening. And
Yeah.
so I think this is an example of where that sort of population health data goes wrong and it informs some of the wrong decisions. And that's my personal viewpoint.
Yeah. Thank you.
Mhm.
Um, I think about that because there's just so much that I know as a survivor too. And I think about, being 20 years out and worried about my daughter and
Mhm.
screening for her and, the age. And you can maybe talk to this question, what is the recommendation for daughters of women diagnosed with breast cancer in general, and then even after the age of 65?
Sure. So the recommendation in general is that women should begin screening average risk, and we'll talk about who's average, but women for average risk should start screening at 40 or 10 years younger than the youngest person in the family, right? So if somebody was 36, then the 26-year-old in the family need to start screening, right? That's not average. That's something different. And
Correct.
so this is why it's so important to know your family history because it's 10 years younger than the youngest person. If you don't know the ages of the people in your family with breast cancer, you're not going to know if you should start screening earlier.
Yeah. And when you say in your family, are you talking your aunts, your grandmoms, your right? All of them, not just
All
her
counts.
mom, right? Just all
And dad's side too, right? Because
and dad's side.
I've heard that myth,
Yes.
like, oh, it doesn't matter what's on your father's side,
Yeah.
or oh, it skips a generation. No, no, it doesn't. And all of it matters, even the cousins. It's why there's certain risk calculators that are better than others because they take into account those cousins and the second and third degree relatives.
Yeah. Perfect. And then if you're over age 65, then, 10 years is 55. So you're still going to screen at 40. You're not going to, right?
Exactly.
You're going to make sure you're going down. Yeah.
Yep. And the task force also says that women should screen every other year until the age of 70. That is their recommendation, right? And they're saying that, yeah, let me make sure I got that right. Up to 74, excuse me.
74.
Yep.
Mm-hmm.
So women age 40 to 74 go every other year. And then once you hit 75, the guidance or the grade is an I, insufficient. They're saying there's not enough evidence to assess the balance of benefits and harms of screening mammography in women 75 or older. This is different than the Society of Breast Surgeons and the NCCN. Remember those letters, 4 letters,
Yeah.
NCCN, right? That's the cancer Bible. So if when in doubt, go to NCCN. But we recommend that you get screened until your life expectancy is less than 10 years, right? Or until you wouldn't do something about it. So if you come from a family of women who are, living in their 90s and they, 101 years old, and if you're 85 and still putting on lipstick and driving, you
Mm-hmm.
should probably get your mammogram.
Yeah.
Mhm.
Sure. I know that shared decision making is so important, and they can really have aggressive tumors if they don't get screened, right?
Yeah,
And they
yeah.
stop screening at 74 and they still have a long life left, depending
And
on
it's
their
really
family
sad.
history.
Yeah,
Yeah,
it's sad to see. You want those golden years to be just that, to be golden. And you don't want to be
absolutely.
having, larger cancers in your armpit and needing chemotherapy. Like if we're gonna find it, let's find it really tiny so you can just do a lumpectomy and maybe not even do radiation now. Because there's some good studies looking at de-escalating for elderly patients. We're
Yeah.
not doing as much aggressive stuff, but that's when we find it early. But it really breaks my heart to see older folks who said, my doctor told me to stop getting screened and now they have cancer that's spread to their lymph nodes and they're on blood thinners and they have heart conditions and they have all the things that make surgeries and chemo really risky.
Yeah.
So, from my perspective, it's easier to do that once a year study than it is to have cancer that's spread to your lymph nodes and need more aggressive treatments.
Yeah. Terrific. Thank you. All right. One other area to a couple other areas. There was a lot in this documentation. So tell me about dense breasts, because what's now recommended for our women with dense breasts? This is difficult. This is difficult.
Well, let me tell you what the task force says. Uh, the U.S. Preventive Task Force says that there is insufficient evidence to suggest that supplemental imaging for dense breasts is what should be recommended. And that conflicts with the FDA, that conflicts with the NCCN, that conflicts with the Society of Breast Surgeons. And so what we're hearing is this recurring theme that the U.S. Preventive Task Force might be just a bit out of step and maybe a little tone deaf. And that's, again, my personal opinion. And many more clinicians are starting to agree with this. Like, how many more women have to die, you know?
Yes.
And so the deal with density is this. Breast density is categorized into 4 different categories. I should have put up my PowerPoint so I could show you density.
Mm.
I'll see if I can find it while we're talking.
Okay. All right.
But it's divided up into category A, B, C, and D. And the categories are to help us to know how much white stuff is on the screen. Because the more white stuff you have, the cloudier the sky, the harder it is to see a certain
Yeah.
type of cloud. And so category A density is 0 to 25%. I'm kind of getting up there in age. You see all these white hairs showing, right? So I think of it in terms of console TVs. I think I've told you this before.
Good. I
So the
love the
console,
analogy. I was going to tell you to do it. It is a
that's
perfect
it.
analogy. I saw it so clear.
Yeah, so console TV, right? Remember those big floor model TVs? There's a little bit of snow on the screen, little bit, right? Category 2 is scattered fibroglandular, and I found my slide. I'm going to share my screen and
Perfect. Do it.
just to kind of give you a okay,
Good
here we
visual.
go. All righty, can you see that? And
Not
can you
yet.
see it? Okay, stop
There it
share.
is. Yep, you got it.
Okay. Can
Mm-hmm.
you see if I put it on this view? Or
Perfect.
you? Okay,
Got it.
so
Yep.
here we go. This is the density. Category 1, predominantly fat, or category A.
Mm-hmm.
Category B, you got some stuff on some static on the screen, right? It's 25 to 50% dense. Category 3 or category C in some letters. Now you got 50 to 75% of your screen's got snow on the picture, right? And so it's getting harder to see the masses. Category D or category 4, extremely dense breast. This breast looks like a snow cone or cotton candy, right? And it's really hard to see. Is there a mass here? Is it here? Is it over here? Where are the nodules? And so it's so important to know your breast density because this determines whether or not you should get some sort of supplemental imaging. And I wonder if I have, so the difference between 2D and 3D mammograms.
Yes.
And the preventive task force says, well, either one's okay. They said, either computer assisted or tomosynthesis. That's the word for 3D mammograms. But you see what I see. This looks like an ink blot. This looks like a tumor. Looks like a spider.
Yeah.
And so 3D mammograms are important because it gives you the dimensions between all this density so you can see if something's really in there. And so the reason that the whole deal with the density is that the FDA and the government is now going to require us, but I think in September, to tell every woman how dense her breasts are. And
Mm.
we already get that letter. Many of you get it. And it says at the bottom, the sensitivity of mammography for heterogeneously dense, 50% or more, the sensitivity of mammography for this much snow and this much snow is diminished. And so mammograms can miss things.
Yes.
So they tell
Yes.
you how dense it is so that you can get supplemental imaging. And the FDA says you should get an ultrasound. And the state of Pennsylvania says we'll pay for that ultrasound or that supplemental imaging. The preventive task force says, not enough evidence.
Mm.
So it's getting tricky and it's going to get even trickier. But what you should know is that if you have dense breasts, not your doctor says, oh, it feels dense, see you later. But the
Yeah.
white stuff on the screen, if you have that, you should talk to your doctor about supplemental imaging. Can I get an ultrasound? If that doctor says no, I would say, why not?
Yeah.
Yeah.
Thank you, Dr. Mo. Okay. Do you think, is there anything else that we missed? I feel like we got through dense breast, we got to the age of 74. That was another one that was, that was tricky. Every year, we're talking about going every year. A lot of these things just are in conflict with the NCCN
Yeah. Yeah.
and
Yeah.
the Society for Breast
Breast
Surgery.
surgeons. Yep.
Yeah,
Those are the two. The doctors who take care of cancer. Those are the ones you want to listen to. And
yeah,
your primary care. It's tough because PCPs follow the preventive task force, right? So the primaries don't follow the cancer guidelines. And for a while back in 2015, they really kind of messed everybody over because they said, oh, women should start at 45 and then go until 55 and then go every other year. And everybody was like, who's
Much
on first, you
confusion.
know?
Mhm.
And so the gynecology guidelines are slightly different. So when in doubt, go to the American Cancer Society, which or go to NCCN. We did not talk about women at average risk, that statement, you
Okay.
know,
Yeah.
and what people should know is that the screening guidelines are for a technology. They were developed around a technology, which is mammography.
Yeah.
And so the guideline is not a clinical one. It's not the thing that we should do medically because it's sound. It's because of the limitations of the type of technology. Because mammograms use density, it's not helpful in young women because guess what? They have more dense breasts. And so this is where it gets a little tricky because for women at average risk, and who's ever told you if you're average, who's ever sat down and done the numbers? And
Yeah.
if the doctor has, then that's the conversation you need to have with your doctor. It's how do I know if I'm at average risk or if I'm above average? What
Yeah.
tool should that doctor be using? What can, and if that doctor says, oh, you got family history? Yeah, you might be at elevated risk. In 2024, we can be more precise. There
Mhm.
are risk calculators and we can actually do the math. And so this is why you got to know your family history and why you got to bring that family history to your doctor and they can plug all that into a calculator and they can tell you your percentage, your 10-year and your lifetime risk for breast cancer. And if your lifetime risk for breast cancer is more than 20%, you are high risk and you do get screened twice a year. And you do have to talk to a doctor about things like chemo prevention or pills to block estrogen. And you do need to be getting a breast exam twice a year. And you might need some genetic testing.
Yep.
So knowing that history and knowing who's at average risk versus who's at high risk is really important. And we recommend you start having that conversation with your doctor at age 25.
Great.
Yeah.
Yeah. You and I both, we see too many young women, Dr. Mo.
Mm-hmm.
Too many
And
young
too
women.
many Black women, you know, because what about that, right? The
Yep.
preventive task force says there's insufficient evidence to recommend to.
See if we have
I
her back.
lost my power.
Mm.
And there, okay,
Oh,
well, there we go.
no worries. No worries. We got you
Sorry
back. I'm
about
glad
that.
you're on
All
your
right.
phone now.
I'm
Yes.
on my phone because I don't know if the Wi-Fi is back. But what I was saying was for Black women,
Perfect.
there's only one society that recommends screening Black women earlier, and that's the Society of Breast Imaging, or the American College of Radiology, I think. And all the others say we need more data, we need more evidence, and this is why it's so important to participate in clinical trials because we need the studies. We know that Black women are diagnosed at a younger age and a later stage, but they're saying that there's not enough evidence to say we should start screening earlier. They're saying that's due to other factors and not related to age. I don't buy it. I think it's something in the water. I think there's environmental things. I think there's a lot of reasons why young women and in general across the board, the fastest growing demographic of people with breast cancer are age 30 to 39, Sue.
Yeah. Yeah.
And there's no screening guideline recommended for them. There's no guideline. So we got to do something and we
Easy.
got to do it fast because the rates of cancer are supposed to double by 2050. So we got our work cut out for us.
Yeah, for sure. Yeah. Do you have time for a couple more questions, Dr. Mo?
Absolutely.
Okay, so talk about insurance companies. So if the average risk is starting at age 40 and they're saying every other year, but you know, because you're listening to Dr. Mo and says follow NCCN and the Society for Breast Surgeons go every year, are they going to cover it? Are they going to follow this guideline?
In general, they will.
Okay.
I haven't really seen many insurance companies refuse to give a woman an annual because they do say talk to your doctor and it can be shared decision making. So if you go and your doctor says, well, the guideline says you should go every other year, and you say, but I'd like mine every year, please. That doctor should order that and your insurance should honor that. If you have problems, then you should probably see someone like a breast surgeon like me, and we could order that for you and it could still be screening as opposed to diagnostic because the difference as far as insurance is concerned, screenings are covered, right? Because we're just checking, we're doing our global look. Diagnostic means we feel something, we found something, you got symptoms, and that's a different type of study that's not always covered.
Okay. We have another question coming in live from Facebook. So There has been a yoga student and massage therapist pushing thermography. Well, how am I saying
Mhm.
it right? Thermography,
Yep,
right?
thermography. I gotcha.
Thank you. In place of mammograms. Is there
Mhm.
any benefit to this type of screening for breast cancer survivors?
Unfortunately, no, especially not for survivors. But thermography looks at the heat signature of a tumor. So the thought is that the metabolic rate, like your metabolism, right? Things that are growing fast, like tumors, give off a signature, a heat. And there's scans that can pick up that heat, like when you go through the airport, you know? The problem is by the time something gives off heat, it's bigger than you want it to be because not every tumor grows at the same rate. We see grade 1 slow growing tumors. We see grade 2 where the growth rate's kind of variable. And so thermography is not reliable. It's not an approved by any medical society, unfortunately. And it just isn't as they say, ready for prime time.
Yeah.
So no to thermography. You know, I recommend for my patients annual mammography. I recommend ultrasounds for dense breasts. I recommend using MRIs for high risk individuals. So yeah, especially not if you've had cancer. My cancer patients get diagnostic imaging every year. They read it while they're there. They do ultrasounds. They look at it with a magnifying glass. So I don't want less screening for them. I want the best.
Yeah. Thank you, Dr. Mo. Is there anything more that you would like to share with our community? I'm so glad you broke it all down because I feel like that, and please, we put it in the chat. Please read the article because I think we get a lot of the bits and pieces from Instagram and some of the quick facts, but it's really good to go really in depth
Hmm.
because we can understand that there is a lot of shared decision making that needs to be done and that these are not in line with a lot of the Society for Breast Cancer Surgeons and the NCCN. One more question here. This is from Facebook as well. I was diagnosed last year with triple negative and I finished my treatment. How often do I need a mammogram?
Annually. And if your cancer wasn't picked up on a mammogram, let's say you felt it and the mammogram was inconclusive or they found a second spot on the mammogram, you should get additional imaging as well. So if you only saw your cancer, like I'll give you an example. My grandmother was diagnosed with a type of breast cancer. They call it the ghost, lobular. Invasive lobular breast cancers don't always show up on mammos. They don't always show up on ultrasounds. A lot of times they're picked up on MRIs once women feel something and then they got to get biopsies and they get more scans and they find that there was cancer hiding out that they didn't know about.
Mm,
Those are women who should get MRIs. If you had advanced disease and you had PET scans, talk to your oncologist about that too. Most PET scans are based on symptoms. So if you have symptoms, who are we to say you don't? If we have symptoms, then you can get additional imaging as well because it's something that women worry about so much. You know, scanxiety is real. And it brings up a really good question that I saw, Sue, that I know we didn't ask today, but what about these molecular tests like Signatera and all these other things,
yes,
right?
yes. Yeah,
So here's the deal. If you already have anxiety just about your mammogram, how much more anxiety would you have over a test that's inconclusive that said we found a signature for cancer? And then you do the $1 million workup, you get your mammogram, you get your ultrasound, nothing. You get your MRI, nothing. You get your PET scan, nothing, right?
yeah,
Those tests have a high a false positive rate that's not acceptable for oncologists who know just how much one anxiety and energy goes into looking for cancer, and two, how much money a patient has to spend. Like financial toxicity is a real thing.
yeah,
And so if you do one of those types of tests and they say, well, we see some signatures in the blood, what are you going to do? Start chemo? No, you're going to search for it. And if we don't find it, are you ever going to sleep again at night?
yeah.
Right? And so we have to find a test that's not only sensitive, but very specific. It's like with the MRIs. They're sensitive, they're picking up something. But if
Mhm.
they can't tell you where it is, and if they can't tell you what it is and what to do for it, it's going to create more anxiety and fear than be helpful. So the future of imaging and surveillance does look like molecular testing. And we're getting there. But you know, those tests are when the doctor says not ready for prime time, that's what we mean, because think about the people who stay up the night before just a mammogram every year. You
Yeah,
know, imagine you're sticking a piece of litmus paper in your eye, you're looking at your tears, you're doing saliva, you're doing all these things to look for cancer, and then you can't find it.
yeah, yeah, good point. I know we're desperate for a better test, Dr. Mo, I feel like, right? We're desperate for it, but there comes a cost.
We are.
And that's going to really hurt you emotionally. And if you're not going to live your life because you're so worried, then that is
Yep.
not a healthy way to go, right? We have to stay balanced. Another
I,
question from Facebook.
well, exactly.
Yeah, one more
Mhm.
question here. Can you talk more about how to find lobular cancer? I don't know about that.
Sure. In lobular cancer, the difference in ductal versus lobular, ducts are the hollow tubes that carry the milk to the nipple. Lobules are the lumpy, fluffy parts that make the milk. I think about it sort of like clouds that make the rain, and then you got these tubes that carry the rain to the nipple. When cancer starts in the ducts, it tends to grow in big lumps that pop out of the duct like a can of Pillsbury biscuits. I use food because it's easy to understand, right? So the pressure builds up, or Jiffy Pop popcorn, whatever, however you want to think about it. But there's a lump that tends to form, and then it tends to break out and start to spread. Lobular cancers, the cells just sort of drift out of the cloud, so it's like raindrops.
Hmm.
So imagine now you're not looking for a cloud, you're looking for raindrops, a lot harder to see.
Yeah.
And so it's why they're harder to detect. It doesn't mean they're more aggressive. It just means that maybe mammograms aren't the best technology to detect them. So that's why we use ultrasound. It's why we use MRIs for lobular carcinomas. And they can also be in both breasts. So when a person gets diagnosed with lobular cancer, you have to check both sides and make sure there isn't a mirror image cancer happening on the other side.
Yeah.
It's a really good question.
It is. No, our community is so active. So I'm so glad we have all of this recorded. Of course, you can always go back and listen again. I know I will. We appreciate you, Dr. Mo, so much. Is there anything that you want to leave our audience with? Just as far as what are next steps, as we think about these guidelines, right?
Yeah.
We have to really be a self-advocate, right? And make sure that we're listening to what you're telling us now, that every year having shared decision making, making sure you're understanding your risk. Do your family history, talk to your family about it.
Mm-hmm.
Because there are tests that you can talk to your physicians about to understand what is my risk. And if it's greater than 20%, correct, Dr. Mo?
That's right. Yep,
Then we
twice a
want
year.
to know that.
Couple things last things people should know. There are risk calculators for folks who don't have cancer. So if no one's ever done one with you, or you're thinking for your family, how do I know my daughter's risk? The risk calculator that I recommend that's the most robust is called the Tyrer-Cuzick, Tyrer, Tyrer-Cuzick, Cuzick. And you can Google it, and you can put in all your family history and some personal stuff like your weight and your height and your age you started your menstrual cycle, and it'll crank out a number. And that is something you can take to your doctor as a tool to have a conversation. It's important to know yourself, know your body. Nobody knows you better than you.
Yeah.
And
Yeah.
that's you a good advocate, because you can say, this wasn't there before. I know my body. And so it's hard to do because nobody teaches us what normal feels like. Doctors don't do a good job of that anymore. And they recommend against the clinical breast exam. They're saying, stop feeling them. You're making women worried. Well,
Hmm.
people still check for melanomas, and how many people know what a melanoma looks like? But here you go, checking all over, right? And so how
Yeah.
dare we tell women not to check their own breasts and do self exams?
I know. I feel like that should actually start younger, just with our young
Yep,
girls. Learn about their periods. They have to learn about how their breasts change and look and know your body. Keep
exactly.
saying that we have to start this at sixth grade so that these
Right.
conversations about dense breasts aren't happening at age 50, where I'm like, what is a dense breast? I never knew that. Never was told.
Oh
Yeah.
my God. Yeah, you're so right. And so that's my other advice is start young, have the conversations, be your own advocate, know your risk factors, and know that, sometimes cancer happens and there aren't any risk factors, right? And it's not anyone's fault. Breast density is not a bad word. It's what we got.
It's the
And
technology. That's the problem. That's what we have to look at dense breasts. It's not the dense breast. It's the technology. It's not
it's true. It's not well suited for dense breasts.
well
And so
suited.
there is innovation. We'll have to do a future Zoom, and we'll talk
Yeah.
about, what's happening on the innovation front to address this, because there's a global crisis that's happening. But, optimize your body for wellness. Focus on the principles that Unite for Her teaches, because it teaches you that no matter what life throws your way, this body can do hard things. This mind and this spirit is built for resilience. And that's no matter whether you are high risk, whether you don't have cancer, whether you're battling cancer, whether you're metastatic and you're a thriver, you're in treatment, out of treatment, focusing on those principles will help you to feel empowered and like you're not a sitting duck waiting for cancer to happen, but you're doing something about it so your body can fight and be well and feel well no matter what state it's in. So that's my advice always. And yes, get screened, get screened, get screened, talk to your doctor about the type of screening that's right for you. And don't be afraid, like take somebody with you or hold yourself accountable to someone. Maybe you and a girlfriend meet up once a year for mani-pedi, somebody you don't really talk to that often, but you got a once a year date to get that mammogram together or around the same time. But make yourself accountable to someone and for someone, and you're more likely to do it for yourself. So all good tips and tricks.
It is. I love that you say we can do hard things. We can do hard things, Dr. Mo.
Yeah.
Absolutely. Right. Okay. You told us about the actual calculator, and I did not get it into the chat. Can you just spell that one more time? I want to get it in there.
You got it. It's Tyrer-Cuzick, Tyrer dash Cuzick, Tyrer-Cuzick risk model. If you Google that, you'll see one that's by a company called MagView, and it's an easy, kind of shorter one to understand. And you can do it online. You can do it yourself. There's a lot in the media about Olivia Munn, who she got her mammogram, didn't show anything,
Yeah.
and her doctor said, well, let's do this risk calculator. And they did the Tyrer-Cuzick risk calculator. Turned out she was 37% lifetime risk, so high risk. And then they did the
Wow.
MRI. They found the cancer.
Wow.
Yep.
37%.
Mm-hmm.
Yeah.
Didn't know it. No one ever done it. So if nobody's ever told you if you're at average risk or not, talk to your doctor. That's another take home from here. Tell somebody in your family, do you know your risk for breast cancer? And they say, oh, I got family history, or it doesn't run in my family. Okay, but have we ever calculated that risk? Because if you've had atypia, family history, hormone replacement therapy, there are some risk factors that get calculated into those numbers.
Yeah. Oh, you're the best, Dr. Mo. Thank you. I feel you just empower our community, and it is so important to talk about this to your loved ones, your family, your doctors. You don't have to go it alone. I think a lot of us as women feel like, we can hold it inside and we can handle everything. Be a self-advocate and use your resources. And you, Dr. Mo, are just an incredible resource. So thank you for being here tonight. We appreciate it.
Boy, sorry for the power outage, but I'm
No,
glad.
you're resourceful. Are you kidding me? You're resourceful. I'm like, just wait. She'll be back. I know
You
she'll be back. I know this woman. She'll be back.
love to do it. I appreciate
Yeah.
you. Thanks.
Well, thank you. You have a good night. Thank you, Dr. Mo.
See ya.
Well, I hope that was very valuable for everybody, because I think we end up answering a lot of questions, right, that we heard about with the guidelines and who we need to really look towards. And that Society for the Breast Surgeons and the NCCN and understanding our risk. It was a good segment. So thank you for joining us tonight. The Ask the Experts is here for you. We have the best that come on our show, and we are grateful for them. Just keep in mind that we have one every month. This one we added two, and coming up at the end of the month on May the 30th at 1 o'clock, we're going to have Dr. Reeder here. She'll be joining Erin to answer all your questions about processing trauma and strategies to overcome emotional and psychological roadblocks. So please join us for that. You can ask questions ahead of time, just like we did tonight. And you can go right to uniteforher.org/experts for all of your questions. Again, we want to thank our sponsors. We can't do what we do without them. That is our digital sponsors that are our presenting sponsors, West and Merck and Daiichi Sankyo. And we have additional support from Lilly, GSK, EO, and Gilead Sciences. All right, until the next one, thank you for joining us tonight. Bye-bye.